I'm Dr. Sangeetha, Pediatric Intensivist, Aster RV. Today I will be presenting on decay. The definition of decay according to the ISPAT guidelines, basically it is a biochemical criteria: hyperglycemia more than 200 milligram per deciliter, venous pH less than 7.3, or serum bicarbonate less than 15, ketonemia more than 3 millimole per liter, or moderate to large ketonuria, that is 2+. Epidemiology, there is wide geographical variation in the frequency of decay at onset of the diabetes. Rates inversely correlate with the regional incidence of the type 1 diabetes. Frequencies range from 15 to 70% in Europe and North America. Decay at diagnosis is more common in younger children, especially less than 2 years of the age. Actually, the exact incidence and prevalence of diabetes in India is not known. This is published in Indian Pediatrics, wherein that is Anju Virmani has reported the Diabetes Atlas 2017 estimates that there are 128,500 children and adolescents with diabetes in India. However, extrapolating from a prevalence of 0.54 per thousand population in expatriate Indians in UK, this figure translates roughly to a prevalence of 7 lakh in a population of 122 crores, assuming all type 1 diabetes patients are diagnosed and all survive. Then where are these children disappearing? It has indeed long been suspected that many children were dying before or soon after the diagnosis, reducing the prevalence sharply. There is a term known as Euglycemic Ketosidosis, that is modestly elevated blood glucose concentrations. This especially seen in partially treated diabetics, those who have consumed little or no carbohydrate, those who have starved for a long period, a low carbohydrate, high fat diet, or the off-label use of SGLT2 inhibitors. These are the drugs used mainly in type 2 diabetics, wherein they will be just advised diet and exercise along with these drugs. Risk factors for the decay in newly diagnosed, it is more commonly seen in younger age group, less than 5 years, delayed diagnosis, low socioeconomic status, and country with low prevalence of type 1 diabetes. In cases of known diabetic, it is occurring at the frequency of 1 to 10% per patient per year. More commonly seen in omission of insulin, especially basal bolus dose. Insulin pump failure, which is nowadays it is seen less commonly because of the better coaching given to the parents. Intercurrent illness with increase in counter-regulatory hormones. Previous episode of decay itself is a risk factor for recurrence of decay. And adolescent psychiatric disorders are the other risk factors. Main goals of therapy are correct the acidosis and reverse the ketosis, correct dehydration, restore the blood glucose to the near normal, monitor for complications of decay and its treatment, identify and treat the precipitating event. About fluids, despite severe dehydration, patient blood pressure and urine output are maintained. This is basically because of the elevated counter-regulatory hormones, ADH secreted in response to hypovolemia. The current weight should be used for calculation of the fluids, not the previous weight. In obese patients, we can take the ideal body weight. For body weight more than 32 kilos, volumes not to exceed the twice maintenance. These are all ISPAT guidelines. Body surface area for children more than 10 kg, you can take 1500 ml per square meter per 24 hours. And use of crystalloid, use crystalloid, not the colloid. There are no data to support the use of colloids. And there is a lot of debate about the fluids, whether we have to follow the ISPAT guidelines, BISPAT guidelines. That I will come to the later. So based on that, we will calculate the maintenance fluids based on the above criteria what I have mentioned. Plus, we will calculate the deficit based on the venous pH. If it is less than 7.3 or bicarbonate less than 50, we'll take it as mild, that is 5% dehydration. Moderate is between less than 7.2 pH, bicarbonate less than 10, and we'll take it as 7% dehydration. and severe as 10% dehydration. Basically, this fluid deficit is corrected over 48 hours period. Objectives of the fluid therapy are to restore the intravascular volume, replace the sodium and extracellular and intracellular fluid deficits, improve the GFR. There may be that will enhance the clearance of glucose and ketones. And there is a debate about whether to give a fluid bolus or not. First, to remember that these children should not be treated like septic shock. That is, bolus doesn't mean you have to give it over 10 to 15 minutes. Always bolus is over 30 to 60 minutes, only if they are in shock. That is more than 20 ml per kg, you can give there in shock. And according to the ISPAD, if they are not in shock, you can consider if their volume depleted 10 ml per kg over 1 hour, that is 60 minutes. BISPAD even says the child is in shock. If despite 20 ml per kg, if there is no restoration of the circulatory volume, then you can go up to 40 ml per kg. But again, there are no studies to say like which one to choose. And the other thing is, when you have given so much of fluid in a child with hypokalemia, delicate heart, child can become fluid overloaded. Plus, there is a risk of cerebral edema. So that is why in DKA they say basically the fluid what you are giving is to improve the end organ perfusion, not to treat the hypovolemia. And when you are treating the end organ perfusion, the fluid required is less compared when you are treating the hypovolemia. Robert Tasker, he has just reviewed 2 studies. That is in one of the article, Fluid Management During Diabetic Ketoacidosis in Children, Guidelines, Consistent Recommendations, and Clinical Judgment. This is basically to debate about the PECAN study, that is fluid trial. One second, I'll just present about the PECAN study. Okay, PECAN study, that is 1389 patients were reviewed. It is a prospective randomized controlled trial. The results of this study suggest that a range of fluid infusion rates and fluid sodium content may be safely used to treat the decay in children. No significant differences in the frequency of either altered mental status or clinical diagnosis of cerebral edema in any of the treatment arms. The 2 arms used here are 0.45% saline and 0.9% saline, and long-term neurocognitive outcomes. So Dr. Robert Tasker has reviewed about PECAN study. The comments made here are basically in this study, out of 1389 patients undergoing randomization, 1263, that is 91% had GCS score of 15. It's very important. And 99%, that is 99, 7% had GCS score of 14. And 28, that is only 2% had GCS score of less than 14. In essence, the test of fast versus slow fluid strategy is strongly influenced by the patients with decay who are fully awake at presentation. So where is the risk of morbidity? Here it is impossible to answer. As we see from the fluid trial, such a proposition with an outcome of brain injury in less than 1% of the decay episodes, it is unlikely testable in a future sufficiently powered clinical trial. So at the end, we still don't know which is right, which is wrong. Taking all the above together, there is clearly a need to realign the variance in the decay fluid management reflected in the STRS, BISPAD, and NICE approaches. Even though we have gold standard clinical information from the PECAN decay fluid trial, the relevance of that information to all pediatric patients presenting with decay needs careful consideration, which means we have to individualize the treatment. And regarding the use of saline, plasma light, RL, which one to choose? All are, basically there are many studies, only one trial, that is PINK trial done in Chandigarh. According to this, the incidence of new or progressive AKI and resolution of AKI were similar in both the groups. Plasma light A was similar to 0.9% saline in time resolution of decay, need for RRT mortality, and length of PICU and hospital stay. So coming to the electrolytes, Serum sodium is unreliable measure of degree of ECF contraction. It is basically because of the dilutional hyponatremia and hyperlipidemia. And corrected serum sodium, that is expected serum sodium in the absence of hyperglycemia. This has to be considered. As the blood sugar are decreasing with insulin and fluids, measured serum sodium concentration should increase and corrected serum sodium should decrease or normalize if not. If not, it is an ominous sign of impending cerebral edema. Coming to hyperchloremia, it is basically a ratio of chloride to sodium more than 0.79. Basically, the acidifying effect of chloride can mask the recognition of resolution of the ketoacidosis when total base deficit is used to monitor the biochemical improvement. To avoid this, point of care bedside beta hydroxybutyrate levels have to be done every second to fourth hourly to help this. So coming to the anion gap, usually it is around 20 to 30, more than 35, suspect there is a concomitant lactic acidosis. Basically, it helps in tracking the resolution of ketosis. The limitations are, it is unable to differentiate the mixed acidosis. That is when there is a concomitant hyperchloremic acidosis plus ketoacidosis. It is difficult to interpret. And degree of hyperchloremia is not quantifiable. But still, we can use a formula that is the chloride ion contributing to the anion hyperchloremic acidosis can be quantified. That is the difference between sodium and chloride is 32. So based on that, 32 to 35, based on that, we can comment about the base deficit contributed by the chloride ion. Coming to the insulin therapy, it is basically to restore the normal cellular metabolism, to suppress the lipolysis and ketogenesis. It is important to remember that only fluids can reduce most of your hyperglycemia. Then why insulin is given IV? The answer is to restore the normal cellular metabolism, to suppress the lipolysis and ketogenesis, because body is decompensated. When you are using the insulin therapy, always avoid IV bolus, because studies have shown it can precipitate the cerebral edema. It can precipitate the shock by decreasing the osmotic pressure. It can worsen the hypokalemia because it has aldosterone-like effect. And number two, resolution of ketoacidosis takes longer than normalization of the blood sugar levels. That is the indication to give the insulin. Increase the dose of insulin if no biochemical improvement. Decrease the dose of the insulin if hypersensitive, that is hyperosmolar, coma, infants, provided acidosis continues to resolve. Again, coming to the dose of the insulin, it is mentioned you can use it between 0.05 to 0.1 unit per kg per hour. And there are no studies wherein there is a harm when they have given 0.05 or 0.1. But most of the patients will require this much of insulin. There are no studies where more than 0.1 unit per kg per hour are used. And even they suggest if they are responding to the low insulin dose, you can use it between few studies have used between 0.03 unit per kg to 0.25 unit per kg per hour. Maybe when the patient is not improving acidosis wise, but glycemia is under control, instead of decreasing the insulin, you have to add dextrose up to 12.5%. The dose of the insulin usually remains at 0.05 to 0.1 unit per kg per hour until resolution of the decay. That is pH more than 7.3, bicarbonate more than 15, and beta hydroxybutyrate level less than 1 or closer of the anion gap. Again, hyperchloremic acidosis should be kept in mind when we talk about the anion gap. Hypokalemia, it is important to remember that always intracellular potassium is depleted in patients with decay. It is because of transcellular shifts caused by the hypertonicity, acidosis, glycogenolysis, and proteolysis secondary to insulin deficiency. Potassium is lost from the body because of the vomiting and osmotic diuresis. Volume depletion causes secondary hyperaldosteronism, which promotes the urinary potassium excretion. Replacement therapy is required regardless of the serum potassium concentration, except if renal failure is present. If the patient is hyperkalemic, defer the potassium replacement therapy until urine output is documented. So the thing is, you have to start the potassium from the beginning itself. The maximum recommended rate of IV potassium replacement is 0.5 millimole per kg per hour. If hypokalemia persists despite of this dose, then you have to reduce the insulin dose. Always it is important to remember, profound hypokalemia in untreated TK is rare, but it is lethal and it requires vigorous potassium replacement. Delay this, in such situation, you can delay the start of insulin therapy until serum potassium levels are more than 2.5. And coming to which one to use, potassium chloride, potassium phosphate, or potassium acetate. When you use KCl, there is a chances of hyperchloremic metabolic acidosis, or when you use potassium phosphate, it can cause hypocalcemia. Though, so both the things should be kept in mind. So you can use combination of KCl and KPhos. Coming to the phosphate, depletion of intracellular phosphate occurs. It is lost as a result of osmotic diuresis induced by insulin. Hypophosphatemia is exacerbated by insulin, which promotes early entry of the phosphate into the cells. Clinically significant hypophosphatemia may occur if IV therapy without food consumption is prolonged beyond 24 hours. So main thing is, even if they are depleted phosphate wise, magnesium wise, even in all the children with decay, there are no studies that treating the hypophosphatemia or hypomagnesemia has improved the outcome. So usually we treat when the phosphate is less than 1. So because it can cause metabolic encephalopathy and acute hypophosphatemia in a patient with pre-existing severe phosphate depletion, especially which is seen in malnourished children, it can lead to rhabdomyolysis. Coming to acidosis, it is basically reversible by fluid and insulin therapy. Insulin stops further keto acid production and allows keto acids to be metabolized, which generates bicarbonate. Treatment of hypovolemia improves tissue perfusion, renal function, thereby increasing the excretion of organic acids. Controlled trials have shown no clinical benefit from bicarbonate administration. So when to use the bicarbonate? Because bicarbonate therapy may cause paradoxical CNS acidosis, and rapid correction of acidosis with bicarbonate can cause hypokalemia. So it is beneficial only when in the rare patient with life-threatening hyperkalemia or unusually severe acidosis, less than 6.9, that has compromised the cardiac contractility. If considered necessary, cautiously give 1 to 2 millimole per kg over 60 minutes. If acidosis is not getting corrected despite of insulin and fluids, then you have to suspect insufficient insulin to switch off the ketones. That time you may have to again prepare the fresh insulin preparation, or just see whether the dose is properly delivered or not. Other thing is, this is the most important cause. Other things are inadequate resuscitation, any fluid calculation error, or sepsis when there is a associated lactic acidosis, or is there a concomitant hyperchloremic acidosis. Here there is no treatment required if it is a hyperchloremic acidosis, or if there is a associated drug intake like salicylates. Most important thing is renal compromise. In here, even the sugars will not get controlled. And always it is seen that good correlation between the beta hydroxybutyrate levels and severity of the acidosis. So whenever the serum bicarbonate was 18, beta hydroxybutyrate levels were 3. With bicarbonate of 15, corresponding beta hydroxybutyrate were 4.4. This is derived from this study, a retrospective review of the records from 129 hospitals by Sheikh Ali M. You can go through this in detail. But because what is the problem in diagnosing the decay only by based on the biochemical parameters is, it is basically we consider pH and bicarbonate, which are both are not as much as reliable because there is a respiratory alkalosis, that is a respiratory component. You don't know where the pH and bicarbonate are lying in presence of PCO2, which is frequently changing because of the minute ventilation of the patient. So when you take the beta hydroxybutyrate values along with the other parameters, in 15% of the patients, there is a diagnostic problem with the bicarbonate, pH, or glucose. When the conventional definition of decay was used in 15% of the patients based on your bicarbonate, pH, and glucose, it did not fit into the decay definition. So coming to hyperosmolar hyperglycemic state, it is characterized by extremely elevated serum glucose concentrations and hyperosmolality without significant ketosis. Here it is important to remember your pH and ketones are not much deranged. The incidence of HHS is increasing, and a recent study found that it is in 2% of the youth with type 2 diabetes at presentation, considerably less frequent in children and adolescents. The usual symptoms of decay are usually absent in HHS. Obesity and hyperosmolality make the clinical assessment of dehydration challenging. Basically, hypertonicity, which usually the osmolarity will be more than 350. So it preserves the intravascular volume, indicating signs of dehydration may be less evident. Urine fluid boluses may be considerable and may need replacement. In most of the decay patients, we won't even catheterize and we won't replace the urinary losses. But when you are dealing with a patient with HHS, you may have to consider replacing the urinary losses. And here the main treatment lies in aggressive replacement of intravascular volume as compared to the treatment of children with decay. Always the initial bolus should be more than 20 ml per kg of saline. Thereafter, you can switch to 0.45 to 0.575% saline. A fluid deficit of approximately 12 to 15% of body weight should be assumed. Whereas in case of decay, usually about 7 to 10% we will consider. Measure serum sodium frequently and the sodium concentration in the fluids adjusted to promote the gradual decline in the corrected serum sodium. Here it is important to remember we have to measure the sodium frequently in compared to the decay patients. Mortality associated with failure of the corrected serum sodium to decline with treatment. It is an indication for hemodialysis. So your serum sodium, corrected serum sodium is not coming down with the treatment. That indicates child is for hemodialysis, and it is associated with the high mortality. Hemodialysis has resulted in 80% survival in contrast to 20% with peritoneal dialysis. With adequate rehydration alone, that is before insulin therapy, serum glucose should decrease by 75 to 100 milligram per deciliter per hour. So the bottom line is don't start the insulin early until unless your serum glucose is reducing by 75 to 100 per hour. And because early insulin administration is unnecessary, because tissue hypoperfusion in HHS commonly causes lactic acidosis, and basically you're giving insulin to treat the ketoacidosis. So to treat the hypoperfusion, you have to give the fluids. Other thing is a rapid fall in the serum glucose and osmolality after insulin may lead to circulatory compromise and venous thrombosis unless fluid replacement is adequate. And here we recommend low dose insulin between 0.025 to 0.05. Once plasma glucose is decreasing less than 50 mg per deciliter per hour with fluid alone. Coming to the electrolytes, in general, all potassium, phosphate, magnesium are lost in a greater extent in HSS compared to decay. And bicarbonate therapy is contraindicated. It increases the risk of hypokalemia and adversely affect the tissue oxygen delivery. It is important to remember that usually we won't put central lines in decay patients, especially the femoral, because they are more prone for venous thrombosis, and it is commonly seen hazard in HHS. So prophylactic heparin is recommended for the children more than 12 years. Less than 12 years, still it is mechanical support. And other problem with the central line is it causes erratic insulin delivery. Rhabdomyolysis may occur in children with HHS, resulting in AKI. Monitoring creatine kinase concentrations every 2 to 3 hours is recommended for early detection. For unknown reasons, children with HHS have mild clinical manifestations consistent with malignant hypothermia with high mortality rate. Usually these patients are treated with dantrolene. Of the 3 reported patients with HHS treated with dantrolene, only 1 has survived. Coming to cerebral edema, In population studies, the mortality rate from decay in children is 0.15 to 0.3%. And this 0.3% is developing countries like India. Cerebral injury is the most major cause of mortality and morbidity, and cerebral edema accounts for 60 to 90% of all decay deaths. Incidence is very less than 1%. Mortality rate is 22 to 24%. And 10 to 25% of the survivors have significant residual morbidity. So basically, the diagnosis is clinical. There are cases presenting with edema prior to any therapies. So those treated before respiratory failure had lower rate of mortality, that is 30%. Lesson is treat early. So exact etiology is not known. I'm not going to the details of which. Degree of edema correlates with the degree of dehydration and hyperventilation, but not with the osmotic changes during the treatment. So just don't rely upon your serum osmolarity or sodium values. Risk factors for cerebral edema, basically whoever has been treated with alkali therapy, that is bicarbonate, those who have reduced bolus insulin dose, younger age, less than 5 years, and new onset diabetes. Greater hypocapnia at presentation after adjusting for degree of acidosis. Increased BUN at presentation, more severe acidosis at presentation, and marked early decrease in the serum effective osmolarity. These were the risk factors. Symptoms may develop within 12 hours, but they can develop up to 48 hours. So for the early diagnosis, you can assess based on the headache, which is unusually severe after beginning of the treatment, altered sensorium, incontinence, cranial nerve palsy, papillary edema, Cushing triads, and desaturation. And there is a classification system for early diagnosis of cerebral edema known as MU classification, wherein the diagnostic criteria, major and minor criteria are used. Some 15 points are there. You can refer, I will share it later about that. Basically, treatment of cerebral edema is mannitol, 3% saline. Intubation may be necessary. Reduce the fluids to half maintenance. Neuroimaging if intervention is required, especially if you are suspecting any intracranial hemorrhage or anticoagulation in case of thrombosis. Many patients with decay have subclinical cerebral edema revealed in MRI. One more point I want to highlight is the diagnosis of cerebral edema just based on the GCS is difficult, because GCS is meant mainly for TBI patients, head injury patients. In case of decay, there are other factors also should be kept into consideration. Most of the decay patients will be lethargic, acidotic, with mild reduced sensorium at the time of presentation. So you should be careful based only on the GCS to comment about the cerebral edema. So the appearance of the DI, that is increase in the urine output, hypernatremia, it suggests there is a herniation causing interruption of the blood flow to the pituitary. So there are a lot of debate about use of mannitol or 3% saline. Basically, there are no studies. Most of the studies before on cerebral edema are on mannitol. So there are no at least harm of using mannitol, and it has helped the patients. But otherwise also, if you consider, nowadays we are using more and more 3% saline because of the BTF guidelines and the TBI trials, wherein 3% saline is the first indication in TBI cerebral edema. So from that time onwards, we are using more and more 3% saline. So from 1999 to 2009, use of mannitol as a sole agent decreased from 98 to 49%, and use of hypertonic saline as a sole agent increased from 2 to 39%, and use of combination therapy increased from 0 to 10%. And it is important to remember that in decay patients, especially those who have received combination therapy, had higher mortality rate than patients who received single agent. And interestingly, use of hypertonic saline as a sole agent was associated with higher mortality than mannitol alone, especially in patients on mechanical ventilation. And this is one of the study wherein, in fact, only study wherein it was a 11-year retrospective analysis of the mortality, wherein it was shown that increasing use of the hypertonic saline over mannitol in the treatment of symptomatic cerebral edema was associated with higher mortality. Coming to intubation and mechanical ventilation in decay, if possible, avoid intubation, that is a dictum, because it is a physiological difficult airway. An increase in the PCO2 following intubation above the level that the patient had been maintaining may cause CSF pH to drop, worsening the cerebral edema. And there is an article where it is beautifully explained about the physiology of cerebral edema and hyperventilation in decay. So, in fact, we consider, according to this, again, it is by Robert Tasker. In fact, we consider that the implication that aggressive hyperventilation should be avoided. It may be counter to the logic of adaptive physiology, unless they are for exhaustion. However, if intubation and ventilation are undertaken, consider a target level of PaCO2 appropriate for estimated bicarbonate in the CSF, and treat with great caution those presenting with arterial pH of 7. So they have used some calculation. It is a derived thing for calculation of bicarbonate in the CSF in this study. So another article recommends ventilating to a PaC2 level existing at the time of when the intubation is performed. It is important to remember that in unconscious patient, secure the airway, empty the stomach contents, especially with the large glucose containing diet, to prevent the aspiration. Not only that, usually decay patients have gastroparesis. So if they are full stomach, you have to empty the stomach, because once you start the insulin, gastroparesis will be released, but they can have a rebound hyperglycemia. So coming to respiratory failure, in fact, it is a main indication for intubation. So you have to keep it in mind, following things into consideration, which are quite treatable conditions. Severe hypokalemia, severe hypophosphatemia can lead to respiratory failure in decay. ARDS, because of the fluids, when you use in such patients with the, it can be cardiogenic also, cardiogenic pulmonary edema in patients with renal failure, and respiratory complications of cerebral edema. These are the causes of respiratory failure in decay patients. Thank you.
Okay. So I think it was quite extensively handled, especially the decay aspect of it. There are so many controversies irrespective of, how many cases we manage. So a few key points are, how do you assess the dehydration of the patient? What weight should you take? So you do your calculations, and then what's a simple way of assessing the dehydration apart from clinical assessment? And clinically, many people actually struggle. So there's an objective way of doing it based on what blood gases you find, and then like tailor your fluids. How much fluids to give, how to calculate that one is still a controversy. So there is no right or wrong answer there in terms of selection of fluids and the volume of fluids. So if you are sticking to ISPAD, or if you are sticking to BSPAD or whichever, just make sure that you follow the track, because these are all trialed and tested, guidelines. So it's not good enough that we pick one of this, one of the other. So try to just make sure that it is uniform. And then some controversies about the type of fluid to be selected. I think the PGI study was quite useful because they looked at plasmolite, normal saline, and those. They still, like, many of us pediatric intensivists still feel more comfortable doing plasmolite rather than just normal saline. And then I see our endocrinology team doing even 0.45, saline. And when we see all these studies, it didn't really make a difference. So I think we should just be vigilant of that. Do what you're used to, because you will know how to identify those changes. In terms of the volume of fluids, how you correct your dehydration matters. And then once you are on the track, what exactly do you monitor to decide the volume of fluids that you're giving? Corrected sodium is something that you should document. The anion gap is something you should watch out for, apart from the blood gases. And checking the blood ketones, equally important, okay, because it will guide you, especially when your acidosis is not improving, and also helps you to decide when you're trying to switch off insulin. So those are like some of the things that I can think of initially. And then for the worst case scenario, as what Dr. Sangeetha was trying to say about the hypokalemia, make sure that you have started the potassium supplements, especially most of the Decay kids, they would have peed, and they would be more, in fact, in the polyuric stage in spite of the dehydration that they are in. So majority of the children actually you will see, but because we are in a tertiary center, we need to know that we can anticipate these kind of issues, that they may be in ARF by the time they come, because they haven't been treated on time with fluids. So it's important to like identify how to recognize that one and start the treatment accordingly. So hemodialysis is something you need to be thinking of a bit more aggressively in those kind of children, and then manage it. Yeah, try to avoid central lines for insulin is a key point as well, as much as possible. Okay. And then if your patient is having cerebral edema, the choice of anti-edema and whether to do combination or whether to do individual, I think many people right now are more comfortable using hypertonic saline. There's no right or wrong answer. I think people are used to using hypertonic saline and they'll continue to use it. I don't know whether we need to make a major change based on that 11-year study which says that
So basically, it is mentioned even in ISPAD that there is no harm of using mannitol and it has helped. So for whoever previously used in all the cerebral edema, this thing, most of them have used mannitol and they have found good efficacy of mannitol. That's the only reason why they are using the mannitol. And now why this another argument for against mannitol is they say once you give mannitol, it causes extravascular, removing the water fluid from the intravascular to the extravascular. So that will dilute the blood, again worsening the cerebral hyponatremia. But in fact, what they argue is this is just a transient phenomenon. Soon, if urine output is good, mannitol will get excreted into the urine along with the water. So again, there is sodium is maintained. That was the argument for this thing.
So the trade-off for that is actually maintaining the intravascular volume also. The trade-off is you have a lot more fluctuations of blood pressures and the swings that happen with mannitol compared to hypertonic saline. So the swings are more dangerous for cerebral edema than the continuous thing. So I don't know, in my own mind, probably physiology-wise, hypertonic saline seems
the only thing is why 3% saline most of them started using is basically because of your TBI. What they have mentioned is the pathophysiology of cerebral edema in TBI may not be same as DKA patients. In DKA, it is a transient phenomena. Once the decompensation is very short period. Once you start treating them, it becomes better quickly. Whereas in TBI, it is a long process. It is not within 24 hours, patient will be all right. So that is the thing that they are worried about the 3% saline. And one more thing, what I have noticed is my postgraduate saying child was in shock, I have given the bolus. So most of the time we are wrong in assessing, making the diagnosis of shock. Basically, because there is a hypocapnia itself can cause vasoconstriction. So again, in DISPAD, one of the criteria used for shock is CFT. So alone based on the CFT, you cannot say the patient is in shock. So most of the time they require maximum 10 ml per kg per hour fluid. If they are in shock, then think better twice whether really they are in shock.
Good point. Good point. And then if you are, hyperventilating, I mean, what should be the CO2 targets, especially when you're ventilating the child, in cerebral edema. And that's always a big challenge. I remember Robert doing that comparisons of the
I've not
CSF,
gone through the depth
bicarb and
of
all
the
of
thing.
that.
I
Yeah.
think that was a very beautiful article
Yeah.
mentioned. You have to see
It's quite
that.
an old article.
But
actually.
it is
I think, yeah. It's quite
physiology is
topical.
explained
Yeah.
better.
So, and then you gave a very elaborate thing about HHS, which was very useful. We hardly see, so I was just like, it was quite useful. Lot of points there. So a lot of information is there in the slides. So well done, Sangeetha. And then it will be useful to share this slides as well with people. Okay. Any other questions from anybody else? You can share your challenges of how you looked after decay kids. So what I just observed from various things, at least in our unit where we need to have consistency, is have a column for corrected sodium, measurements to be documented, anion gap to be documented, so that we know our patient is getting better. And then track the potassium and phosphate and calcium also when we are like monitoring, apart from just the glucose alone. It's just a reminder for us to say these are all the consequences of our treatment, and so these should be monitored, and ketones. So these are the ones that we should document. Yeah.
One more thing, what I noticed is rather than just diagnosing the decay, always anticipate the complications, which are very less but can be life-threatening, especially this HHS. So if you have a doubt about it, maybe just send one serum osmolarity, which we are not sending regular.
So there is an entity of hyperosmolar along with decay, where the fluid, because we had seen one, especially it's seen in the infantile type of diabetes when you are treating. In those children, no matter how much of fluid you give, the acidosis is not getting corrected. In one of the child, what we had done is, instead of giving 0.1 insulin, we had gone up to 0.3 units of insulin for almost 48 hours, and then only we came down. Because there we didn't know whether it was actually decay, and then later on when the baby discharged and followed, it turned out to be some genetic cause of diabetes mellitus type 1. So that baby was challenging.
No, basically one of the genetic entity, some 6 to 24 deletion something, I don't remember. There it is more common, HHS. That's what has been given.
I don't know now which category, because
And sometimes HHS and decay can coexist. That is one more.
Because that time it becomes a challenge to give how much of volume and how much, because if you see it is both, in one you give more fluids, in another one you give more insulin. So it becomes quite challenging. The another thing what we noticed is whenever you're giving treating a patient with DKA, when you're following the ISPAT guidelines, no, not ISPAT, the British guidelines. The British guidelines, the fluids are comparatively on the lower side, and then the potassium correction takes longer time, in those patients. They will take, if you're treating an ISPAT, the potassium does not give you much problem. But if these people, always we will need a central line, because very frequently we will be giving potassium.
The current ISPAT guidelines, bottom line given is follow the ISPAT guidelines. So have not gone to the ISPAT, because the previous ISPAT 2015 was very cautious with the fluid. Yeah, hardly maximum dose that given is 40 ml per kg. Whereas the present guidelines suddenly says you can go up to 40 ml per kg. So there is lot of discrepancy. ISPAT is between Milwaukee and ISPAT. Milwaukee, if you treat according to that, it is fluid overload. Fluids are even more there, and it is only 24 to 36 hours. Whereas here it is very less. So ISPAT is between that. But there is no hard and fast, you have to stick to the same fluid bolus. Based on the monitoring thing, you can always come down on the fluids based on his response.
What I found was, very interesting observations, because I practice in both countries. I found that if we are practicing BSPED here in India, they take a longer time for the dehydration correction and for the sugars to return to normal, the acidosis to clear, and the hypokalemia Okay, these are like something that I notice here, and I'm invariably needing to, I do track the corrected sodium, and I invariably liberalize the fluids. As I'm treating within the next like 4 to 8 hours, I would have seen that the corrected sodium is still in the dehydrated range. And so I have to increase and liberalize the fluids. Whereas the same thing, if I do it in the UK, I find that it follows like so beautifully. I never had to face any of those issues. So I don't know whether some issues are to do with the ambient environment and the insensible water loss and things like that, which are more probably in Indian setup than what we find in the UK. It's just very weird. But having practiced in both centers, when I came to India, I noticed that I have to chase fluids a lot more. So I remember Dr. Kavita Bhatt following the Milwaukee protocol very vigorously initially when I was working with her. And I used to get so scared with the way, compared to BS Pet and Milwaukee is like two extremes. And we used to get very tense about the way the fluids are being managed. So me, Rakshay and Kavita, but we used to be on like different warpaths. We'd be like, allow us to manage the fluids and you just stick to insulin like that. I think the ISPAD, after it came, we had a little bit of harmony between both the teams. It's just something to.
I felt based on the assessment of dehydration 5 times 7
Correct.
15 is basically based on your pH
Correct.
and bicarbonate. And we don't know Indian children how they are before the onset of treatment, whether already they were having low pH because their growth is affected, they're quite malnourished. So many patients I've seen coming with 6.9 pH. That means according to these guidelines, you have to give bicarbonate because your heart is liable. But we have not given bicarbonate.
Never given.
So I think we have to consider in a different way other than whiskey.
And Nandita is trying to stop him. Nandita?
So for us, at least when we struggle the most is when we see this like 16, 17 years old, because it's very difficult to do it as a pediatric thing. But the adults kind of use a very different fluid strategy, which is on the eccentric, that more fluid bicarb is the strategy they use. Because we had one particular child who was like 17 years old, quite obese. Whatever we did, how much of a fluid we did, it didn't work at all. Then when we involved the adult ICU guys, and they pushed fluid, like how we would treat like a hypovolemic shock, that was the state they were doing. And they even pushed bicarb to a very, very, very fast rate. So it was a bit scary, but child did well. So I think when we are struggling in that in between age, maybe we can get help from the adult ICU guys, because they do it very, very differently.
Excellent point. Excellent
No,
point.
I feel basically there should not be much difficulty in treating the adult DKA patient because the complications are much less as the child ages. Most of the complications are seen less than 5-year-old.
No,
In
we are
adults, what
cautious
we are
because of
worried is
that.
HHS in adults and adolescents. So again, which
So
is
the younger age group kind of come out very quickly because we stick to the guidelines and we see the outcomes also better. But when they are little on that older age group, we kind of find it a little struggling regarding the insulin and the fluid management.
consider ideal body weight rather than
No, it does not work.
No, it
We have
doesn't.
No, it
seen-
didn't work for that boy. Ideal body weight did not work. They used a very
Changing
different
the
fluid
not
management.
the same what you have decided initially itself.
They will need more fluids, especially when they are obese and all those things.
Obese especially, yeah. There was one more thing which I was just thinking, and I haven't seen much studies, which was basically for cerebral edema monitoring. Whether we need to like do the optic nerve sheet diameter for these kids and just document to say, in the DKA patients, how does it, what do we see? What's the baseline?
Okay.
Does it matter?
Okay.
When you are like thinking through, this child is complaining of headache and like, I don't know what's going on. So I think it will be a good study for a DNB student to like look through. So I'd suggested that in Rainbow. I don't know whether somebody has like picked it up and done it or not. But
Only
it
thing
is
doing it is very difficult in a
It's subjective.
hyperventilating child and
Yeah.
smaller age group child. Usually here ventilated children, we can give sedation and do the things, but in DK patients, it could be little difficult.
No, that's what I think what we got, just like how we did for that metabolic child,
Yeah.
we just kind of taped it and
Yeah.
then just did it. So I think we need to just start thinking
Yeah.
laterally a little bit just to kind of work around it. Just for our own sake. I was just thinking what's innovatively that we can do. It's just something that we can think of. And, I think if there are some difficult decays, we need to keep a parameter. Okay, within 24 hours, they should have reversed. If they didn't, what were the criteria, what were the parameters, and why did it become difficult? So if we look into those factors as a study and then analyze it, then we'll probably understand better. Because I think we have to analyze our own data. Then only we'll understand the challenges a bit better.
Because what in DK, most of them will go in that very nice way,
Correct.
but when they give problem, they
Exactly.
really give the problem.
Exactly. So
And
that's what we
regarding
have
the
to look
insulin
for.
0.3, 0.2, then we have to reevaluate from the beginning.
Exactly.
Why the child is requiring 0.2.
Exactly.
Most of the kids do very well with the 0.1.
Yeah.
So there is no
In
need
fact,
to go
I have
to
used
0.05.
0.05 most of the time.
Yeah, maximum you can use is 0.1. Like, in fact, this time he has even mentioned 0.025 also
Yeah.
started.
Yeah.
So
I
one
have
of
not
the
seen-
previous studies they have mentioned even they have used from 0.03.
That's what, see,
So-
most of the diabetes, they follow that that textbook manner. But when they give problem from all the ways. And it is like sitting there and then thinking what this is not, what this is, those things. I just wanted to know about the ventilation part, ma'am, especially when you're intubating a child with DK. Like it's very difficult because they will be hyperventilating. The moment you give a vac, then suddenly they're going
Correct.
to
You have to like hyperventilate to maintain
because
that
we have
CO2.
seen like one child losing in front of us, especially with the bad cerebral edema, and like how exactly to go about, and then what are the parameters to set on the ventilator.
Yeah.
Like one, yes, you have to target the PCO2 because you're taking off that the natural imbalance. So what are the parameters you will be setting? Like
I
you have-
normally go by whatever rate the child is breathing at.
okay.
Okay, I keep it close to that, 5 to 10 breaths plus minus.
Okay.
That's what we'll do rate wise.
Okay.
And then reassess, monitor your ETCO2 and correlate your PCO2 and then see. Okay, I have done even like we started with very phenomenal rates like 30, 40.
Oh, okay.
Like that.
Okay.
Upfront.
And then how will you target bicarbonate? Because in DK, another thing is once you're intubating and going
Correct.
into a mechanical ventilator, your bicarbonate is not going to be,
Yeah.
it is all artificial bicarbonate.
Yeah.
So how are we,
It will settle.
no, it will settle.
It
No,
just
basically
takes
you're
12
not
to
going to
24
see the
hours.
bicarbonate, it is the PCO2 which you're going to see.
No, but
Because
you're going
bicarbonate
to,
takes time.
but you're going to treat your DK simultaneously. So you need your bicarbonates
So
also.
that is ongoing, but PCO2 should be kept in mind. What was the PCO2 before the intubation?
That was just maybe for cerebral
Just-
protection.
No, what I'm saying that is for cerebral protection. Now
Your
your
decay will automatically
automatic-
set. Because of your insulin and
Huh.
everything, it will settle
Settle.
down. If your fluids and your insulin, that
Oh.
will settle
And
down.
what is the target tidal volume for them? Minute ventilation will be too high just by adjusting the rate.
No, that's what you just look at the ETCO2 and then you keep adjusting it.
ETCO2 how much to target?
No, that's what it depends on what your patient came in with. So they came with a respiratory rate of like say 40, 50.
see sometimes
You
they
keep
will have
that
a PCO2 of
40
just
to
8 or
50
3,
plus
8, 9,
minus.
that I've seen.
Correct.
See, they will come with a PCO2 of some 2, 3, especially with the cerebral edema.
I go with the respiratory rate and I just set it according to that. And then you may overdo it a little bit. Okay. Your tidal volumes generally like 4 to 7 ml per kg. That's what we have done.
The
Okay.
rates you can just keep.
The rates only are the ones that we kind of tweak it.
Like if you have a
You want
PCO2
to have a little bit of good chest movement. So 4 to 7 ml per kg, anything roughly. If they're very obese, you may have to do a bit more because we can't determine. Okay. I have hardly managed some 5 or 6 venti patients, like in my 20 years. I've hardly managed 5 or 6.
that's very rare. But only
Yeah.
thing if it goes bad.
Yeah. it just goes to show that it is as rare as it is. And I have managed almost once a week at
What
least.
about sedation and
decays.
paralysis?
Yeah, full at that time. And then, you know,
And AK, another one thing is decay.
hemodialysis upfront.
Sugars will never normalize until unless you improve the AKI part.
Correct.
So early hemodialysis.
Early hemodialysis. Yeah. And if you ask anybody, they know that I am very pro hemodialysis. I'm not a PD person.
Basically, I have not seen much complications of DKA. So when we see them, then only we can just.
Only in like the sick dengues who were like bleeding away like to hell that I can't even safely put a line, that I was obliged to do PD. And those all I have lost only. I haven't seen any survived ones. Although Saumil used to tell me that, you know, I'm very biased. And we're very aggressive, even liver failures, this one, that one, everything, just early CDB. So, okay. Anyone else want to share their gyan? Can feel free to. Okay, then we'll end the conversation.
Yeah, for me, it is the switching over time from IV insulin to subcutaneous insulin.
Yeah.
So there's always this doubt whether we should give full correction or we'll start once the pH improves or bicarbonate improves. And
pH,
also,
pH has to improve, bicarb has to improve, acidosis should improve, ketosis to some extent should improve.
and another part is with when we are all used to endocrinologist being there
Yeah.
to start subcut, but if an endocrinologist is not there, then to switching over to subcutaneous insulin, need to discuss a little about that.
Okay. So what the general rule of thumb which endocrinologists have told us is, you work out how much insulin, especially for newly diagnosed decay, then you work out how much insulin was needed in the previous 24 hours, and then you calculate it and divide it through the day. Okay, earlier we were using more like Atrapid, so we were doing 2/3 in the morning and then 1/3 in the night, like that. Okay, so then we have now started doing the basal bolus regime. Okay, so that is how the calculations are done. You work out how much insulin was needed in previous 24 hours, and then you divide it. Okay.
Another thing is, if they are mild decay, we can just stick to even subcutaneous insulin rather than only IV if they are able to regulate the fluids themselves.
I have hardly seen that working, but
We have seen on our two in Narayana. We just started some maintenance fluids, even subcutaneous insulin.
Especially those already know, just pH of 7.3 to hunger or
Just mild decay.
mild. And what we see is like, even though the textbook says like, moderate or severe, like pH of 7.1, but actually, we will see so many children with
6.8.
but within 24 hours of insulin, they would have been actually fine.
okay. Okay, team. Thank you, everyone. We'll end the conversation. Thanks, Sangeetha.
Thank you.